We continue on down our respiratory tract. We showed the nasal epithelium, and today we're down into the pharynx. The pharynx, then, is a fibromuscular tube. A fibromuscular tube. And it's going to extend from the base of the skull, to the level of the 6th cervical vertebra, down to C6. C for cervical. So let's see its relationships now. So we'll have the base of the skull here. We'll have the floor of the nasal cavity here. And we'll put in our larynx down here. So this is base of skull. And that would make this our nasal cavity. And this would be our oral cavity. And this would be our larynx, down in the neck. So with this, then we can begin with our pharynx coming down as a posterior wall. And this area that's behind or posterior to the nasal cavity, logically would be called then the nasopharynx. So let's put in nasopharynx here in yellow. So it's obviously posterior to the nasal cavity. Now, what do you know about the nasal pharynx that we've had previously? What tube do we find originates there? Pardon? No, that's cartilage. Right? The eustachian tube, right. Originates. And where's the eustachian tube going? To the middle ear, correct. Goes to middle ear. Why do we need a tube going from the nasopharynx into our middle ear? To equalize the pressure on each side of the eardrum, your so-called tympanic membrane. It equalizes air pressure on tympanic membrane. That's official name for the eardrum. So you know that when you're in a plane and you want your ears to pop, so to speak, you yawn. How do you get that air in there? It comes up through your mouth, your oral pharynx into your nasal pharynx, your eustachian tube into your middle ear. All right? So what kind of epithelium are we going to have in our nasopharynx? If you're building a nasopharynx, what kind of epithelium do you want to put there? Simple squamous? No. Pardon? That's right, you're right, you're starting right. Pseudostratified, columnar ciliated epithelial cells with goblet cells. So for the moment we'll call it respiratory epithelium, okay? With respiratory epithelium here. But I want you to say it. So it's going to be pseudo-stratified, columnar, ciliated epithelium with goblet cells. So now that will bring us down. What lymphatic tissue do we have in the nasopharynx? A tonsil, what's it called? What part of the body are we in? So what kind of tonsil are we going to call it? Pharyngeal tonsil, right. So you've got the pharyngeal tonsil here. All right, that'll bring us down now next to our oral pharynx, which will be posterior to the oral cavity. This is purely diagrammatic here. So our oral pharynx. Put in green. Is posterior to the oral cavity. What kind of masses of lymphatic tissue are we going to have here? Tonsils, right, but what are we going to call them? It's a good guess, but it's not right. That's okay, you're trying. I like it when you try. Okay, we're going to have the palatine, because remember the palatine was going to be here, and what's at the base of the tongue? The lingual, right. You didn't say it. Do you know it? Can you tell I'm looking at you? No, I'm looking at her and she's not smiling. Yes, all right. Palatine, the lingual tonsils. So what kind of epithelium are you going to have when you get posterior to the mouth? Pardon? Do you want respiratory there? You're putting in all those hamburgers and all that potato chip and everything and that delicate little respiratory epithelium? Stratified what? Squamous. Right, so you want stratified. Good thinking. Stratified, squamous epithelium. No, it's true you have air there, but you don't want, the air can go by, a little bit of stratified squamous epithelium, but you don't want your delicate cilia and all of those goblet cells, right? So that's our oral pharynx. Now the next division of the pharynx will be the laryngeal pharynx. And since our larynx is down here, we'll do our laryngopharynx will be the continuation of the tube down here. So as we can see, it's posterior to the larynx. So you can see how you're following that one wall will be solid, but the rest is open because we have to have air then that's going to go down in this direction. But what kind of epithelium do we want then in the laryngopharynx? What is going down the laryngopharynx? Pardon? We're posterior to the larynx. So what kind of epithelium? No, you have food going down, right? Stratified what? There are all kinds of stratified. You've got to be correct. Stratified squamous. You want something that's tough like you have on your skin. That's stratified squamous. It's being abrased all day long. You don't want any cilia out there, right? So you want stratified squamous. So you can begin, by the time we finish, you'll be able to answer all these because you'll understand why the body's built the way it is. Not that complex, just needs thinking. Yes?
Are any of the phalanxes separated by any barriers?
Any barriers? These divisions? No, it's just a continuous tube. It just gets different names because it has different functions. Sometimes it's pure air there. Sometimes it's food and air. Sometimes it's just food, right? There's a reason for everything, right? So let's be sure we've covered that well for you. Right, let's continue then with our larynx. Move over for a division of our respiratory system. We did the pharynx here. Larynx. It's again about 4 to 5 inches long. It will be surrounded by cartilage. It will be in the anterior, this is anterior neck. The cartilages are obviously there to keep the lumen open. We don't ever want the air passages to close. So there are actually 9 cartilages. The larynx is complex. There are 3 paired and 3 unpaired. We're only going to take the unpaired for examples just because of time, so you have a general idea of why you need them. So unpaired cartilages. First, we'll have the thyroid cartilage. the largest. It's the first part of the larynx. What does thyroid mean? Any idea at all? Shield. Thyroid equals shield. So it's going to look like a shield to some people. This is our thyroid cartilage. And most people are aware of its common name. What's its common name? Adam's apple. And you can feel it right protruding. Now in puberty, in males, it increases its size. Increases size at puberty. In males. Because, as we'll see in a minute, the voice is developed behind it, and so the voice will deepen at puberty. Why is it important for the voice to deepen? So the male sounds more threatening. Well, you know, the young male voice is a beautiful soprano. Not going to scare anybody. So becomes more threatening. We'll just put voice. All right, so that's our thyroid cartilage. We'll take two more and then come back to the voice. The next one will be the cricoid cartilage. Cricoid. And it will be just immediately inferior to the thyroid cartilage. And it looks like just a straight piece of cartilage from anterior, because this is an anterior view. But if we look at a lateral view, we'll see it has quite a different shape. So if this is anterior, this is what we had seen. But posterior, it expands. So this is anterior, this is posterior. Have you ever taken a ring that you have on your finger? Do any of you wear rings? And look at it sideways? It looks thin here and then expands back here. They say it looks like a signet ring. That's what you see in the literature for its shape. A signet ring shape. And the other unpaired cartilage for the larynx is the epiglottis. What do you know about the epiglottis immediately? What kind of cartilage is it? Elastic, if you learn one thing. So all the other cartilages are hyaline, right? The only one here is elastic, is the epiglottis. So you know what epi means? What's epi mean? Upon. What is glottis? I'll show you what glottis is, and then we'll come back to it. We're going to look at a longitudinal view of the larynx. Tube with these cartilages. We'll see a fold of mucous membrane in the wall. Fold of mucous membrane. And the superior one is called a false vocal cord. False vocal cord, or fold. They're using the term fold more frequently now. It used to be. So this first one is a false vocal fold. Can anybody make it vibrate? Does anybody have a cat? A cat? Kitty cat? Nobody has cats anymore? A couple of you. Does your cat purr? Yes. Yes. Do you know how it purrs? By vibrating this false vocal cord. Can anybody here purr? You ever tried it? No? Just sits there. So this vibrates with cat's purr. Aren't you ever curious how it makes it sound? Now, inferior to the false vocal cord is the true vocal cord. Or fold. And we're going to take a superior look at it. Stand up behind the tongue and look down the larynx. Oops. Superior view down larynx. And we'll see these two folds. These are our true vocal folds. And laterally, we'll have muscle. The so-called thyroarytenoid muscle. The retinoid after one of the cartilages we're not going to study. So this is our thyroarytenoid muscle. And the area between the vocal folds is called the glottis. So our X's represent glottis. Area between the folds. So when the thyroarytenoid muscle contracts, it applies tension to the folds. So contraction here. Tension on folds. And will raise the pitch of the voice. Don't you think it's amazing when you hear your beautiful singers that you listen to all the time to think what is causing that wonderful sound? If somebody wants to know what a vocal cord looks like, you just take your hands and put those two folds together, right? And all you have to do is contract. See them change? For all those beautiful sounds. But of course it resonates in your sinuses and other areas, quality bone you have and so forth. But to get those beautiful sounds, can you make it? No, you're too close. You have to leave air in the glottis. See, the glottis is right there between. You've got a huge glottis. There you go. That's better. All right. But at least it tells you now why it's called an epiglottis, because you'll have this piece of elastic cartilage up here. So when you, let me just take off some of the writing here. If I have my tongue up here, at the base of my tongue, here I'm going to have this cartilage. And that will be my epiglottis. So every time you swallow, your tongue goes back, your epiglottis goes down. So the food that you've just put down, your oral pharynx goes into your esophagus back here. So you have that protective device so you don't get the food coming down in your larynx. So let's move on then with these to what do we call inflammation of the larynx? Laryngitis. Everybody knows that one. That's inflammation. You know your itis, inflammation of the larynx. So we move on from the larynx. What's the next part of our respiratory system? Where are we going to take the air at after we've left the pharynx and the larynx? Pardon? Trachea, sure. It's all on the board, right? So our next one is trachea. It's about 4 to 5 inches long, too. And it will connect, then, the larynx with what? With the bronchi, sure. Our next division. Got to prepare this air to get it down to where it can be effective. So the trachea then consists of a tube supported by about 16 to 20 C-shaped cartilages. Shaped cartilages. What kind of cartilage? You know it's not fibrocartilage, and you know it's not elastic cartilage, so what's your third cartilage? Hyaline, good. So now we're going to have our trachea coming down, and it will have these rings of cartilage as we see it. This is an anterior view. I'm not going to put in all 16, just representative samples. Pardon? Obviously, yeah. Get a person with a neck long, right? So let's take a cross section through one of these. cross-section of trachea. And we're going to have a lumen, of course, because we've got to keep the air going down. So this is my lumen. And then I'll have this C-shaped cartilage. This is anterior. This is posterior. I'll have an opening of my C posteriorly. So it's going to keep this lumen open. Well, you say, well, why? If it's just keeping the lumen open, doesn't it circle it completely and keep it open? So this is my hyaline cartilage in yellow. In between the two ends of the C is smooth muscle. Smooth muscle. Now, what structure is immediately posterior to the trachea? In your neck. The esophagus. Good for you. So a cross-section of the esophagus here. It has a loose lumen to expand depending on what you're eating. This is lumen of the esophagus. So what happens when you're talking to somebody and you take a big bite of an apple and you don't chew it too well, and it goes down your esophagus and it's expanding? If you had a solid wall of cartilage here, there'd be no room for this esophagus to expand adjacent to the trachea, right? So this is a safety factor, having this open, so when this gets too big down here and stretches way over, this can move in because it's only smooth muscle. If it were cartilage, you would have obstruction. So it serves that purpose, and it has other purposes that we don't have time for now, but it is an interesting arrangement here. So the trachea has its rings, but they're actually C-shaped. Not complete. And we go from the trachea then down to the bronchi, bronchioles, and alveoli. So next we go to bronchi, bronchioles, and alveoli. So we have our trachea coming down. It's going to branch. And I'm being very careful when I start my branches, accentuating them in direction here. This will be my right bronchus. It's called primary bronchus. And my left primary bronchus. This, of course, was my trachea. So I'm bringing the air down. Why it's designed this way, I don't know. But you see, the right is larger and it's straighter. So if something gets down in the trachea, it can cause obstruction in the right bronchus, because it's larger and straighter can be obstructed more easily. So we go from our primary bronchus to our secondary bronchi, and then we go to our bronchioles. I'm just going to draw them this way. Bronchioles. Down to our terminal bronchiole. Why do I accentuate terminal bronchiole? Terminal bronchiole. Because at the terminal bronchiole, there is no longer any cartilage. You've got support all the way down to the terminal bronchiole. How many of you have asthma? Did you know it was at your terminal bronchiole that constricts and causes you difficulty with breathing because there's no cartilage there? That's a fact. So, asthma attacks here. No cartilage. So you get constriction of your air passageway, your lumen, with asthma. Constriction of lumen. So what do you do about it? You take epinephrine, make it relax. So you can breathe for relaxation. See why you have to know your histology as well as your gross anatomy? Now, as we leave the terminal bronchiole, we come to the respiratory bronchiole, and it differs entirely. Respiratory bronchiole. So it tells you what's going to happen here. The respiratory bronchiole is the structural and functional unit of the lung. Structural and functional unit of the lung. What's the structural and functional unit of compact bone? A version system. What's the structural and functional unit of skeletal muscle? Sarcomere. Good. Always review, review. So now, what have we got here? We've got our respiratory bronchiole coming down. We're going to take cross-section of it. Respiratory bronchiole. And it's going to branch off into alveolar ducts. Do you ever think of every molecule of air you take in? It's got to go through all these passageways to get down and be functional. These are alveolar ducts. Alveolar ducts lined with alveoli. Each one of these little pouches here is an alveolus. So we're down to where the exchange of gases takes place. So CO2 and O2 exchange at alveoli. So how are you going to build efficient alveoli to allow this to take place. What kind of epithelium are you going to use? Stratified squamous? No. What kind? Simple squamous, right. So our alveoli, one, have simple squamous epithelium. But we also have secretory cells which secrete a lipoprotein, plus secretory cells secrete lipoprotein. And what do we call that lipoprotein? Surfactant. 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 Why do you need surfactant? You have all these little alveoli. Do you know how many you have in your lungs? They say about 300 million. So if they stretch them side by side, how big would they, of an area would they cover? Somebody has calculated as big as a tennis court. So a tennis court is about the middle of this auditorium for just your alveoli stretched out. What a surface to offer for gaseous exchange. So we'll just put size of a tennis court. So if your friends ask you, how big are your lungs? Well, if you stretch them out, size of a tennis court. Think about it. So we've got surfactant, but we don't want these little thin layers to stick together. So surfactant prevents the alveoli from sticking. Okay? Prevents alveoli from sticking. So what else do we have here for protection? If you were building alveoli that are sampling the air, what do you want to do? What's coming in that air that you don't want? So we're going to add macrophages. These big eaters in the lung are called dust cells. All this chalk dust is being picked up in my lungs by macrophages, dust cells. That's why I use colored chalk, so I can have multicolored macrophages. Might as well think of a good something that happens with it because they're there. But if you smoke cigarettes, thank you, smoke cigarettes, you're getting all that carbon. Your cilia haven't been careful enough in cleaning it out. They're beating all the time up towards your pharynx, trying to get rid of it. You get carbon down, the dust cells pick it up. Have you seen a smoker's lung? Usually you get that in about 6th grade now, just to get the picture. It's black from the carbon particles. I could tell you stories on that. So it becomes black, but now you know that because the dust cells have picked up those carbon particles. What else do we find down here at our one last point before we stop here? The alveoli have elastic fibers. Now you can reason, sure. Every time you inhale, you want those to expand. Let out, they recoil. So we have elastic fibers here. for expansion and recoil. Again, what's going to reduce the elasticity in those elastic fibers? Smoking. What's the disease caused by when the person can inhale but not exhale? They have a barrel chest. Emphysema. Emphysema, you've heard of emphysema. It's no elasticity. You've taken it out with your hot smoke. Emphysema is your disease. All right, let's review with our slides then. Thank you. We can just begin. All right, here we are with our thoracic cavity. Next time we'll look at the gross anatomy of the lungs. The right lung, which has 3 lobes. The left lung will have 2 lobes, and it'll have a cardiac notch for the heart. The apex is up here above the clavicle. It will extend just a little beyond the clavicle. And the base is right on your diaphragm. In the next one. And here's our bronchial tree. You can see the right bronchus is larger, more straight, so anything coming in will lodge down. It's typical on a medical school test to ask which is larger. This one goes off a little bit at an angle and it's thinner. We'll go to bronchi, secondary bronchi, bronchioles, terminal bronchioles. Next one. What kind of epithelium? You could say respiratory, but then I think you've got to know that it's pseudostratified, columnar, ciliated epithelium with goblet cells. And these are goblet cells. They're so full of mucus that the nucleus gets pushed to the bottom of the cell, so you can always tell your goblet cells from your columnar epithelial cells. In the next one. And what kind of epithelium? Good for you. Stratified squamous. See how different it is? It's thick and heavy and protective. It can be abrasive and not tear it off and rub off any cilia. So the body is just beautiful the way it's designed. Changing epithelium depending on what's there. In the next one. And this is down a bronchus where you're going to have cartilage. You'll have the pseudostratified columnar ciliated epithelium. It's smaller. We have some smooth muscle. But here we have cartilage, so you know you're not down at a terminal bronchial. So when you're taking your lab exam, you see this, you know you're above the terminal bronchial. In the next one. And now we're down at the alveoli. We'll talk about its layers next time. These are alveolus, lots of airspace for air to come in contact with the cells, and then the capillaries will be in here to take away the oxygen and give back the CO2 to get rid of it. In the next one. And this is another one. It said that it was going to show me a dust cell, but it's not very, maybe this one. It's not too obvious. This could be one. Not obviously a smoker's dust cell. Next one. And this just shows an artist's rendition of putting elastic fibers around all of the alveoli so that they can recoil. But you can see what happens when you don't have the elastic fibers. I think that's it.